Acute pulmonary embolism remains a critical diagnosis requiring rapid risk stratification to dictate management, particularly in the era of expanding catheter-directed therapies and advanced hemodynamic support. Immediate priority is determining hemodynamic stability, as this bifurcates the entire diagnostic and therapeutic algorithm. High-risk massive pulmonary embolism, defined by sustained hypotension, systolic BP less than 90 millimeters of mercury for more than 15 minutes, obstructive shock, or the need for inotropic support. Intermediate risk submassive pulmonary embolism, hemodynamically stable but shows evidence of right ventricular strain, which is again subdivided into intermediate high. Both elevated cardiac biomarkers, troponin, BNP, and RV dysfunction on imaging, that is echo or CT. Intermediate low, either elevated biomarkers or RV dysfunction, but not both. Low risk pulmonary embolism, hemodynamically stable with no signs of right ventricular strain and low scores on clinical prediction rules like PESI and SPESI. For stable patients, the years algorithm approach is standard to reduce unnecessary CT pulmonary angiograms. Years clinical decision rule consists of 3 items: clinical signs of deep vein thrombosis, hemoptysis, and whether pulmonary embolism is the most likely diagnosis. These, along with D-dimer concentrations, can be used to assess need for CTPA. In patients without Years items and D-dimer less than 1000 nanogram per ml, or in patients with one or more Years items and D-dimer less than 500 nanogram per ml, pulmonary embolism was considered excluded. All other patients need CT pulmonary angiogram. CT pulmonary angiogram is the gold standard for anatomical confirmation and assessing the RV-LV ratio. Ratio more than 0.9 to 1.0 indicates strain. Bedside echo, critical for unstable patients. Look for McConnell sign, 60 by 60 sign, or right heart thrombus, thrombus in transit. Ventilation perfusion scan, VQ scan, preferred in patients with renal failure or severe contrast allergy. Compression ultrasound, useful when CT pulmonary angiogram is unavailable. A positive deep vein thrombosis in a symptomatic patient is often sufficient to initiate treatment. Management strategies. 1. Anticoagulation. Immediate initiation of anticoagulation, unless contraindicated, is mandatory. Low molecular weight heparin or fondaparinux, generally preferred over unfractionated heparin in stable patients due to more predictable pharmacokinetics. Unfractionated heparin preferred in high-risk patients and those with severe renal impairment, creatinine clearance less than 30 ml per minute, or when immediate reversal or surgery is anticipated. DOACs, directly acting oral anticoagulants, now the first-line therapy for long-term management in most stable patients. 2. Reperfusion therapy. Systemic thrombolysis indicated for high-risk pulmonary embolism. Tenecteplase or alteplase are standard. Half-dose thrombolysis is often considered in intermediate high-risk cases with a high bleeding risk, though evidence remains nuanced. Catheter-directed thrombolysis, increasingly used for intermediate high-risk patients to provide localized thrombolysis with significantly lower systemic bleeding risk. Mechanical thrombectomy, indicated for high-risk patients where thrombolysis is contraindicated or has failed. Large bore aspiration systems have shown high efficacy in clot burden reduction. Surgical embolectomy, reserved for patients with contraindications to thrombolysis or those with clot in transit through a patent foramen ovale. Otherwise, it will cause major systemic embolism. 3. Hemodynamic support. In the setting of right ventricular failure, aggressive fluid resuscitation can be counterproductive by worsening RV dilatation and causing the interventricular septum to shift further, reducing left ventricular preload. Vasopressors. Norepinephrine is generally first line to maintain systemic mean arterial pressure and coronary perfusion to the right ventricle. ECMO. Veno-arterial ECMO serves as a bridge to recovery or intervention in patients with refractory cardiogenic shock. Long-term considerations. Provoked versus unprovoked. This distinction determines the duration of anticoagulation, 3 to 6 months versus indefinite. CT-EPH screening. Patients with persistent dyspnea 3 to 6 months post-pulmonary embolism should be screened for chronic thromboembolic pulmonary hypertension with echo and VQ scan. The management of intermediate high risk, that is submassive pulmonary embolism, has undergone a paradigm shift with the release of recent landmark trial data. For years, clinicians operated in a gray zone between the high bleeding risks of systemic thrombolysis seen in the PITHO trial and the conservative approach of anticoagulation alone. Recent data, specifically from the high PITHO trial, now provides high-level evidence supporting catheter-based interventions as a first-line strategy for these patients. High PITHO ultrasound-facilitated catheter-directed thrombolysis versus anticoagulation, presented at the American College of Cardiology ACC 2026 annual session and simultaneously published in the New England Journal of Medicine. The high PITHO trial is now the definitive reference for catheter-directed thrombolysis in intermediate-risk pulmonary embolism. Study design randomized 544 patients with intermediate-risk pulmonary embolism and signs of clinical severity, tachycardia, low BP or hypoxia, to ultrasound-facilitated CDT with echo system plus anticoagulation versus anticoagulation alone. The primary endpoint was a 7-day composite of pulmonary embolism-related mortality, cardiorespiratory collapse, or symptomatic pulmonary embolism recurrence. Results: the echoes group showed a 61% reduction in the primary endpoint, 4% versus 10.3%. This benefit was largely driven by a significant reduction in cardiorespiratory decompensation. Safety profile. Crucially, there were 0 intracranial hemorrhages in the echoes arm through 30 days, addressing the primary safety concern associated with the original PITHO systemic lysis trial. While high PITHO established CDT over anticoagulation, the PLS trial compared two different interventional modalities, large bore mechanical thrombectomy versus CDT. Findings: large bore mechanical thrombectomy was found to be superior to CDT based on a 5-component hierarchical win ratio. Key drivers: the superiority was primarily due to lower rates of clinical deterioration and significantly reduced ICU utilization, 41.6% for LBMT versus 98.6% for CDT. Clinical takeaway: LBMT provides a single session resolution without the need for an ICU stay for drug infusion, though safety outcomes, mortality and major bleeding were similar between both interventional groups. The 2026 guideline for the evaluation and management of acute pulmonary embolism in adults has introduced a new classification system to refine treatment selection with 5 categories A to E and subcategories ranging from low to high risk for adverse outcomes. Category C, elevated risk. Patients with RV strain and biomarker elevation but stable hemodynamics. The guidelines now suggest consideration of catheter-based therapies or LBMT as an early intervention for those with high clot burden or worsening respiratory status. Category D, incipient failure. Patients who are technically stable but show soft signs of failure, example lactate elevation, persistent tachycardia. These patients are now primary candidates for interventional reperfusion to prevent the 10.3% collapse rate seen in the conservative arms of recent trials. Category A is subclinical, while Category B is symptomatic with low clinical severity score. Category E is cardiopulmonary failure. Here is a comparison of evidence summary. Dose 100 mg alteplase full dose in systemic thrombolysis, PITHO trial 2014. 16 to 20 mg alteplase, that is local, in catheter directed therapy in high PITHO trial 2026. Mechanical PLS 2024, there is serolytic. Intracranial hemorrhage risk 2% in systemic thrombolysis in PITHO trial, 0% in catheter directed high PITHO trial, and 0.7% in PLS trial. Primary benefit, PITHO trial prevented decompensation, catheter directed also prevent decompensation. PLS reduced ICU stay and deterioration. ICU necessity mandatory in PITHO and high PITHO trials because it is infusion. While for PLS, ICU admission is often unnecessary. Ongoing research, pulmonary embolism thrombus removal with catheter directed therapy, PTRAC trial. The study is currently following patients with intermediate risk pulmonary embolism for up to 12 months to determine if early CDT improves long-term functional status and exercise capacity. Results are expected to further refine the lytic free versus ultra low dose lytic debate.